But what's a necessity? Can somebody think about what's necessary in life?
Water. Yeah.
Absolutely. Air, water. Right? In other words, these are necessities by which you die if you don't have them. So we're talking about survival. Right? There are things that you can treat, but then there are things that you need to prevent death. And this is how I open my topic of, if you want to choose cardiology, it's a necessity more than anything else. It's like the air. It's not even water. Because you can go by without water for a couple of days. You can go by without food for a few days, or even a month or two. You cannot go by without air for a couple of minutes. Okay? So, why do we want to talk about cardiology? Well, guess what? Not that it's only important, it's a necessary subspecialty to be around. Now I'll give you the positive and the negatives. Why this loads up. Okay, so cardiology, why or why not? Let's talk about numbers. And those who were here last year have seen some of this. Today we're probably going to elaborate just a bit further. It's the #1 killer in the world. If you want to talk about survival, that's what kills people. It kills about a third of the population every year. That's important. Now, if you want to talk about risk factors for cardiovascular disease, it's on the rise. That's why if you go to any chart, whether it's on Google or on British Medical Journal or JAMA, you'll see that it's the top #1 killer. If you talk about cardiac alone, or stroke alone, or cardiovascular together, all of which take the majority of all countries, whether it's developing or developed countries. So it's the #1 killer. What about in Kuwait? Can you guess? No? Cardiovascular disease.
33.7.
#2 is road traffic accident. So if you want to talk about necessity, the other necessity is trauma or emergency, especially for kids. And I'm not going to try to defend one specialty rather than the other. I'm just giving you facts. Okay, so if I tell you about the risk factors in the GCC countries, what are you going to be thinking about? So, cardiovascular disease, risk factors are diabetes, smoking, obesity, hypertension, dyslipidemia. These are what we call modifiable risk factors, right? So forget about being male or having family history that runs in your genes. But having those risk factors which are modifiable, in other words, we can prevent them if you are a good either GP or a internist. If you want to go on mass media and save a big chunk of people from getting cardiovascular disease, you have to work on primary prevention before they actually reach us. Okay? So these risk factors, if we want to talk about, just a few words about each. The prevalence of diabetes, this is a study that was done by the International Diabetes Federation, which is very well known. Actually, they decided to do their last meeting in Dubai just a month and a half ago, just based on the astonishing numbers that comes from the GCC countries. Guess what? Where are we? We are the top 10 in the world. Nauru is a very small island between Hawaii and Australia. I don't know where it is exactly, but you can look it up. It's about 14,000 people. They have genetic predisposition of diabetes. That's why it's #1. But look, United Arab Emirates, Saudi Arabia, Bahrain, Kuwait, Oman, Egypt, Qatar did not submit their data, but it's up there. We are in the top of diabetes. So in terms of either incidence or prevalence, looking at age is going to scare you. Looking at all age is still going to scare you. So the prevalence is quite high. In Kuwait, today is about 18 point something throughout the population. This is all data from 2000. So this is what they, in 2008, looked at obesity around the world. Look at that. You think that we're thin? No, we're not. We are still on the top 10 in the world of being overweight. This is by numbers, okay? If you look, a lot of people will say, oh, the States is number 5 or something like 32%. Yes, they have huge sizes, but percentage-wise, we supersede them. And if you want to display this just by age, you can look at the prevalence of diabetes. Look, at very young age, between 20 and 40, your prevalence is still up above 5%. And if you reach the age of around 60 and above, you get almost to half of your population who are diabetics. So you see, this is not an epidemic, it's a pandemic, almost. This is the obesity by age, and you can see even the young, from 20 to 24, you have a good percentage. As you age, you get to have more obesity, and as you go more than 50 or 55, you can see there is a significant difference between females and males. So our females are not doing a good job. I'm sorry to say, but part of it, okay, is that we have poor awareness. Part of it is social. Part of it is the weather. Some people can blame the weather of not going out to exercising. Still, that's not an excuse. If we do a good work, we should lose more of these pounds. So this is by gender comparative with the rest of the world. Look at the US in red, look at Kuwait in red. We're really above. Congratulations, females. We're above the States in terms of obesity. So, what about smoking? That's also bad. Of course, there is a lot of underreporting in the red. We know females are still smokers. They are less than males in our part of the world, but still, from very young age, all the way to above 50 and 55, the smoking percentage is still high. Now, we've done even a study on the Gulf, looking at those who had acute coronary syndrome in the very young people, so below the age of 40, and we found that they have high incidence of diabetes and smoking. So both of which, even in our young population, have significant risk factors compared to the rest of the world. So, are there enough cardiologists to take care of this epidemic of disease? So we have so many risk factors, and we have so many deaths from cardiac causes. And how do we think about, is this enough or not enough? We have to always go back to certain data to tell us, is this number enough to take care of this population or not? So what's, let's say, a number? Do we have to take a figure, or it's according to the population?
Ratio.
So there has to be a ratio. And this has been studied in the past, and I don't want to bore you, but I can tell you for sure that we don't have enough and not even close. So, optimal number per cardiologist of the population. What do you think that would be?
5.
Huh?
5.
5 shouldn't.
5% per
5 to 1?
cardiologist.
So 5 patients for one cardiologist?
How much more?
I hope. That's not true.
لا هذا انت قلت الاوبتيمم نمبر
No.
This is good. I can focus on
Okay,
this point.
so one cardiologist for every 25,000 of the population. No. This is optimist. So we're supposed to take care of 25,000 of the population, not patients, but population number. Okay, so if you are in a place where you have 25,000 only of your population, you're supposed to have one cardiologist. مو كلهم رغد. مو كلهم عندهم. So, in other words, what do we have in Kuwait? If we just do a rough map, this is what we have in Kuwait. We take care about 150,000 population for each cardiologist. So already now we're overloaded. And one of the worst places actually in Yemen. It's like almost 1 for 500,000. Scary number.
So,
Yes.
There are only 20 cardiologists according to this number.
Yes. Now, if you want to add not the physicians, the non-Kuwaiti cardiologists, we have we have 70,000. So each one cardiologist is taking care of 70,000 of the population. But I wanted to make sure that we are covering Kuwaitis mostly, because this is what we are going to stay in. This is our country that we will have to spend our lives in. And expatriates come, but they go. They come, they go. And very few of them are actually certified cardiologists. Most are either internists, and they've just got into cardiology because of interest, and they got good, but they are not certified cardiologists. Now, if you want to look at further numbers, this is just a graph. I'm going to pass it. I don't want to bore you with numbers. This is all other specialties. Okay, so it gives you, for example, family medicine, internal medicine. The last row here, you need a big number per almost 500,000, 400 of the population. Okay, you need almost like 50 GPs, almost like 30 internists, and this is display of all the other specialties. This is a study that was conducted to see what's the optimum number in terms of the proper care. And this study has been repeated many times, and they all came up with the same number. That's why I wanted to tell you that in certain places in the world, they had red flags flying, even in British Columbia, I think it was in Vancouver, I'm not really sure. But in Canada, they raised the red flag because they had 9 per 100,000 population. They raised the flag. Where are we? We should raise all our flags. Now, I'm just going to pass through this and tell you, this has been, sort of predicted in 2000. Okay? Dr. Muath Al-Anbe3y, I don't know who the rest were, but they published the data, demographics to cardiology, estimating that there will be a crisis from 1950, looking at how much care of patients. Sort of formulas, I don't know how they got it. But they estimated the year of 2010 up to 2020, when baby boomers would come and have coronary heart disease. That's where the crisis is happening. So we're at it. Okay? Now, to say something about cardiology, what's there in cardiology? We have invasive cardiology, so where you start intervening for patients. And that includes coronary intervention, and non-invasive cardiology, where you can have an imaging like echocardiography, cardiac CT, and MRI. So further imaging, nuclear cardiology, heart failure specialty, it's also still non-invasive in cardiology. And then you have 2 other specialties where you actually combine the 2. both invasive and non-invasive. And that would be in the electrophysiology together with the congenital and structural heart disease training. This is how this play of even how you should be trained nowadays. Because you cannot train and just deal with everybody at the same time. That doesn't work. You have to specify your training and do your best in that field. So, certain things come to mind and questions about what should we do? Do we have a fellowship here in Kuwait? Up till now, we've been thinking about it. We started working on it, although nothing came to life yet. But I think in the next couple of years, we will have a cardiology training only after you finish a baseline internal medicine training. Okay, so if you are a graduate of Kuwait, you should have finished the medicine board to be eligible to go into a cardiology board to train in cardiology. Okay? So the upside, there are many good things that we save a lot of lives. Some of you actually have seen, some of you have seen death, some of you have seen how we started trying to save lives of patients. But we do. We have relatively good outcome because without intervention in congenital heart disease, probably 50% of those who would die have been sick. Because about 30% do not reach the hospital. Another 20% will get sick with time and they will die on it. Any downside? Nothing. No. Of course there is a downside. So the workload is one of the downsides. We do have a lot of demand. The number of hours are long, between 50 and 60 hours per week. That's without calls, huh? And you may have some afternoon work, especially if you want to also do a private sector. That becomes even more of a headache. But there is a stressful part of cardiology, generally. But there are certain subspecialties in cardiology where stress is very minimal. I'll give you an example. There are few things in cardiology that we have nobody available for them. We don't have a person who specializes in cardiovascular imaging like CT or MRI. Not yet. And no one in pipe for training yet as a cardiologist. Okay? 2, the stress in non-invasive cardiology is very minimal unless you take care of coronary care. So if you become a nuclear cardiologist or a non-invasive stress cardiologist, it's very minimal. Heart failure as a specialty can be stressful only if you take care of wards. But the most stressful part of cardiology is when you become an interventional guy, and especially interventional coronary disease. That's when it becomes a bit more stressful than other subspecialties in cardiology. Now, if you want to know certain cases by which we can do certain things that either came to your mind or did not come to your mind, I think we have another half an hour to go over certain things. Do you have any questions meanwhile?
How many years?
How many years?
Training program. Average.
So internal medicine outside of Kuwait would accept about 3 years basic. If you want to be purely internist, you have to do 4 years and become only internist. But if you want to do an internal medicine subspecialty as a baseline, you do 3 years and then you go on to your subspecialty. So you finish 3 years of internal medicine and then you go into either it's GI or cardiovascular. Cardiovascular cardiology is 3 years basic, and according to what other subspecialty you want to do, you add 1 or 2 years. Most of them are 1. If you want to do congenital and structural, you have to do 2.
Where do they work?
Where do they work?
Only the tertiary hospital just or
In Kuwait, I think the future, we hope not to be this narrow-minded subspecialty hospital, because it doesn't really work. If you want to be in a hospital, you need all the ancillary services with you. Because you cannot look at the patient, he comes to you, I have only a cardiac problem. I don't have diabetes, I don't have anything else, I don't have hematological problem. They come as a patient. So you should have all the specialties in the same place. So we're thinking about tertiary care centers. We don't have a single tertiary care center in Kuwait. No, that's not a tertiary, that's a subspecialty hospital. A tertiary care center is like a general hospital, but with all other specialties. And that's the aim when we, inshallah, we do this area to be a university hospital, where we will get all the specialties in one place on top of the general hospital. So it will be another tower somewhere with all other specialties. Okay? So baseline, 3 years medicine, 3 years cardiology, and then according to what subspecialty you want to do, depends whether it's 1 or 2 years. Okay? Now, before I jump to the cases, this is what ends up if you eat that burger. It's really a big one. So really, obesity and diabetes plus really early bad habits is a recipe for disaster. Now, do you have anything that you want to ask prior to jumping to the cases? Yes.
Cardiology, I do it only in the US, there is any other place.
There are other places, but in North America nowadays is the most recommended place, because they focus a lot on hands-on training. It's not only knowledge-based. So they actually push you into taking care of things. Okay? Taking care of things this is what we've been pushing. I mean, I've seen few of the 7th years, right? So we want the internship to be quite early for you guys. We hope to let you take care of a room of either 2 or 3 patients that you actually round on them every day, diagnose them early, you learn from them. Supervised, not unsupervised. But that's one of the best times where you actually learn. Is that somebody comes for the first time, you have to figure out what they have. It's not that you copy whatever is in the file. But you take your own history, you examine the patient, and you have put a differential, and you send them for certain investigations to try to figure out what do they have. And that's how what you should do. Okay? We hope that we can implement this in the future. Although it's going to probably be implemented, inshallah, as a pre-internship, but we'd like to get it even earlier. Yes?
Doctor, generally the patients that come to a cardiologist, do you see the effect of your treatment on them? Is there a specialty that you see immediately the effect of treatment, or do you need to follow them for 10 years to...
So that's a very good question, and that's what sort of pushed me toward cardiology, is knowing about the outcome. Is it a good outcome? That's the first question. The second question, is it a fast outcome? To me, neurologists are one of the smartest people. Neuro. But they can tell you where the lesion exactly, but they can't do anything about it. I joke about it. In other words, they spend a lot of time taking proper history, physical examination, winking scapula. And they can tell you exactly where the lesion is. But how much outcome do they have? Nowadays, they're doing some good work. But still, there is a lot of chronicity in their disease. In cardiology, we're trying to reinvent the wheel. In other words, initially, we had no good outcome in the 1980s. But from the 1980s, 30 years later, we have really surpassed all other outcomes in terms of even regenerating cells of dead cells. Nowadays, they inject stem cells into the coronaries for patients with heart failure and infarcts, and they have documented an improvement in the ventricular function in myocardium. Up to that level. Why? I'll tell you why. Not only because it's a simple pump and some blood supply in it and some valves, it's mechanics. صمامات pump شوية electrical power and شوية blood. But if you want to think about it, since this is an epidemic or a pandemic of disease, industry and research focused on it. And this is one of the biggest research that was ever done. Nowadays, even pacemakers, which is a box that equipped to try to generate electrical power, they are doing a trial, and it's actually probably going to be out, is that they leave a small little capsule inside. They go inside, they implant it in the RV, and they go out. So there is no pacemaker anymore. Just a tiny little thing. They go from the vein, they go to the right ventricle, screw it in, get out, no wires, no skin, no nothing. So you can see how things are, I don't know, maybe we'll fly in a couple of years. With this amount of research, you'd be amazed how things are changing. A lot of surgical procedures that have been done in the past, we're doing them now with interventional procedures. I'll give you an example. Just, actually not last 3 years, a couple of years ago, I had a patient who you would love to have in the exam. Is Marfan's. You know what Marfan's? FBN1 gene defect on chromosome 15. Autosomal dominant. Medial cystic necrosis of the aorta. Dilated. And she wanted to marry. Somebody in the States told her that you cannot get married and you cannot have children. Why? You can adopt. That's what they told her. Adoption will equate. And you can make 1 or 2 cases. So when she came, I gave her a research center. I told her this is new. You can go and have IVF. You can grow embryos, and we can test those embryos. Those who are Marfan's positive are excluded. Those who are Marfan free are reimplanted. So we've tested an embryo for her. We gave her back the embryo. She delivered a healthy baby. So you can see that there are things that you can learn as you go. And whatever we studied in the past was a contraindication is sometimes an indication these days. Like beta blockers was a big no-no for heart failure. It's changing because they start understanding the neurohormonal pathway. Now let me give you another twist, other than just this single case. How do you change things in lives of patients of cardiac cases based on history, physical examination, some of our investigations that we do, because you need to know a bit about all these, including the therapies of what we can do other than what you know, because that's what you need to know about cardiology. These are, I just last night tried to remember what I had in mind that I did not lose in terms of cases. These are 4 cases. 70-year-old patient who had a hip fracture, and some of you know this story already probably. I actually just went to visit him because he's a distant family member. And the guy had his fracture fixed. شلون يطلع عوار؟ عسى ما شر فكرة الدكتور طايح في الحمام. اوه سلامات. زلقت؟ ما زلت. زين العام مكسورة ريلك أنا خابر جايك. يقول هم طايح الحمام. ايش الحمام؟ غير الحمام. He fell 3 times and they're all in the bathroom. So something is in the bathroom. Maybe air ventilation, maybe air ventilation. Then the history comes simple. Might be a little embarrassing, but simple, yes. Simple. So I told him, what are you doing in the bathroom that you fall down? Simple. يعني مرات يكون embarrassing, but you have to ask this question. Are you straining? Because if you are straining, you can have strain syncopate. If you take like a hot bath and you're vasodilated, you have sort of an obstructive cardiomyopathy, you pass out. اختنقت شو صار؟ لا والله دكتور احلق. كل مرة يحلق يطيح. سمبل. كاراتيد هايبر سنسيتيفيتي ديسوردر يسوي كذي. يسوي كذي asystole passes out. حطينا pacemaker, never had another fracture. History. It was not picked up because they thought it would be زلق طاح. He doesn't recall. كل مرة يشوفوه حلو. Second case, 40-year-old female who had ST elevation inferior myocardial function. She was thrombolized in the emergency room, and I met her to do an autopsy. I was doing elective in pathology. I wanted to know cardiac pathology. And I said, لا ماتت صح. You never do an autopsy on somebody who's alive. So, why do you think she died? Well, she could have bled. She could have had, a reaction, severe reaction to the thrombolytic therapy, or she could have had arrhythmia. I was just a bit surprised when I did the autopsy. I found that the heart is completely normal. Feet bleeding, started searching. Is there a bleeding? No. We found a hemorrhagic cholecystitis with a hematoma in the gallbladder. You know why? If you know her history, she's been recurrently admitted with cholecystitis. And because of cholecystitis is just below the diaphragm, it can cause irritation and localized pericarditis. And that localized pericarditis shows as elevation. So if somebody took a proper history in her, they could have prevented her death. Just by, instead of giving her thrombolytic therapy, she has gallstones and recurrent cholecystitis. Instead of giving her thrombolytic therapy, you can take her to the cath lab and look at the coroners. She's young. Nobody even considered. She's 40-old female. So female, no risk factors, comes in with a ST elevation. Why do you want to start immediately with thrombolytic? Find out what the problem is. Now, an 18-year-old karate kid, not really the karate kid, but yes, he is a professional karate player. In other words, he's very athletic. Presented with fever, and he had an upper respiratory tract infection, treated with antibiotics, came back, his fever did not go away, and ultimately the guy had a destroyed aortic valve. A severe abscess with perforation of the aortic valve and aortic regurgitation. It's ugly looking by echo. The poor kid underwent an emergency surgery that night because of severe heart failure. They put a homograft for him because he doesn't want to have a metallic valve because he's a professional karate. But he wants to play. They put a homograft. That homograft got infected. The guy was completely febrile, even with antibiotics. Then he developed lung abscesses. They changed his valve, that got infected. So he was continually infected. And, you know, it just did not make sense to me. Nothing was culturally positive. So we said, do you have anything at home? His valves were native, so he has no congenital abnormality to suggest that he has a nidus for infection. So what we ultimately asked him is, do you have any pets at home? He said, yes, I have a lizard. ما كان في جوجل ذاك الوقت. Lizard. You find something about lizard. Lizard disease. Then what do your lizards eat? Mice. Had something called rat bite fever. His mice used to bite him. He was feeding his big lizard mice. So he got monobacterium monoliformis or something weird that I cannot even pronounce, that was resistant to most antibiotics. Well, we just shifted him to that antibiotic here. Then he had another cell, and he's still alive. He's not playing anymore because he had multiple surgeries. So history made a difference in the first and the last, but killed the middle. Okay. Let's go for physical examination. This is a lady here in Kuwait. When I came in, not when I was in May, I was in chest hospital. 2006. She came in with chest pain and dyspnea on exertion. 64. Diabetic and hypertensive. So, I told her, let me examine you. You wouldn't find anything of coronary disease by examination most of the time. I insisted on examining her. I examined her and I hear a continuous murmur. Chest pain, shortness of breath, continuous murmur. So I said, okay, I'm going to take you to the cath lab. And this is her aortic root angiogram. I don't know if this projects well, but do you see anything abnormal? So, you see this vessel here? That's a right coronary artery. Okay, now there? That's a coronary fistula. So it's originating from the left main, like a worm, huge. It's more than half the size of the aorta, emptying into the right side of the heart. That's why she was having chest pain, because it was stealing everything from her coronaries. She had a huge shunt. So ultimately what I did, it was, she refused to have surgery. I treated her medically for a long time, but then I proceeded with her and I told her, okay, I can fix this probably with a procedure, and I actually implanted many devices in her and I closed it. And she told me, so أنا رديت 20 سنة ورا. See? رديت 20 سنة ورا. Exactly, this is her words. She's a mother of 8. So she sustained whatever she had, 8 pregnancies successfully. So that was a change when you examine somebody and pick up an abnormality. Now, an investigation really helps. Yes, it does. Another patient, 52-year-old, hypertensive African male, came in with exertional syncope. So, I wanted to do an echo because I was just learning echo at that time in Canada, at night. And immediately I called my staff. I said, there is something abnormally moving up and down from the right atrium into the right ventricle. He said, what? I told him, what? I think it's a quad. He said, this guy came in with exertional syncope. we were treating him for, an acute coronary event. I said, yes. But I did a bedside echo, and I saw that the right side is weird, it's large, and he had a huge 9 centimeter, about 9 centimeter thrombus floating around. تي وتروح هاي ما يسوي but this is probably had a pulmonary embolism, but at the same time this is called pulmonary embolism in transit. So you can see a thrombus in the right ventricle going down the IVC. يعني لو تروح يوقف قلبك. So we had to do something. We call the surgeon. Surgeon يقول ها احنا نحط cannulation وين تروح وين القاعد؟ لما اسوي كذي شو اسوي؟ Ultimately we decided with the patient that we're going to give him thrombolytic therapy, and he immediately improved. All of this was gone. This was anecdote لأن ما كان عندنا evidence behind what to do in pulmonary embolism in transit. You have evidence in those who have pulmonary embolism with shock. You have evidence with those who have pulmonary embolism and RV dysfunction. But for those with pulmonary embolism coming with thrombus in transit, شو بي؟ ودك تسوي شيء بس ما تقدر. في thrombus extraction, but you cannot do it unless you have something fixed, something mobile like this. How are you going to catch it? You're just going to dislodge it. Okay. So this is this was last year, I think.
ده السؤال يعني الحلقة اللي فاتت ما تقدر تحط stem from يعني femoral, for example, artery or something تروح back أو from the brain تروح back to the atrium تحط stem أو شيء مشبك يعني وإذا تحركت تلزق.
ما عندنا مشبك نصنعه.
لا أنا عارف.
في filter IVC filter, but the IVC filter is in the IVC, so it's designed to stay in the IVC.
لا واحد بس تصير تحط دقيقة عشان إذا فلتت.
ماكو شيء to stay in the right atrium. There is something called green field filter, but it stays in the IVC. And there are other extraction devices, but they should have a pulmonary embolism that's stuck to something, not really like this. So this is a patient who I've seen last year. Actually, I got a call from Hamid Al-Isa. اللي هو زراعة الأعضاء. لا. Renal transplant. So this patient had been evaluated for renal transplant. So this patient was evaluated for renal transplant, and they were about to remove his dialysis catheter. So he's been chronically dialyzed. I didn't really issue the dialysis catheter, but he called me frantic. دكتور الكاثيتر دش داخل وين؟ بالقلب. So this is his catheter, you see? That's a dialysis catheter from the beginning here, from the subclavian vein, مقطوع قاصة بالغلط يعني. الكاثيتر لازق داخل رايت فنتركل وقاعد فوق طالع برا ما يقدروا يسدونه مني لأن ماكو شيء. So open heart surgery to get it out. I told them, wait, let me do something. You have to be quite creative sometimes if you're a structural heart disease. So, no, I did something else. I went in and I made a snare. Snare نفس التكاكة. عرفت التكاكة؟ مع الخيول والبقر هذا الكاوبوي. ها؟ تسوي كذي وتصيد الكاثيتر من تحت تلقى طلع. So you can get it out, and I'm pulling it out from the heart all the way to the groin from a big venous sheath, and I get it. So you can sometimes be even creative in certain things. The last, hopefully, but not the least, somebody who you know, 22-year-old female developed anasarca after a disc surgery. For 8 months, she's been in heart failure. not knowing what she had. And 5 or 6 different cardiologists did not know what she had. She had just a big heart, right-sided, is dilated, and they wanted to, she was about to quit and go home to die. So I examined her. Just by examining her, I felt a thrill in her abdomen. I told her, you have a fistula from the aorta to your vein. And when you inject into the aorta, you see that the IVC is huge, about 4 centimeters in size. And that's what made the communication between one side to the other. So I had to delineate it and see where that vessel is and try to put a covered stent to isolate it. And then all her symptoms went away in less than 24 hours. Whenever you pass by Chest Hospital, here's the second stage. يتوقع عندك اليوم. Okay? Any question? عارف تصديق نجاح الديش كارديولوجي